Okay, thank you very much. Dear colleagues, it's probably one of the most dangerous presentations now, because every minute I run out of time now is at the cost of your lunch. So I know what I'm doing, but I try to keep to give a brief overview on the role of PET-CT scanning in thyroid disorders. Now, when we talk about PET-CT and thyroid disorders, it's good to realize that there are some aspects we have to discuss. And one of the most important things at the beginning is the possible tracers currently available for thyroid imaging or thyroid cancer imaging. And to my knowledge, FDG and iodine 124 are the only indications described in literature so far. What are the possible indications? Well, of course, thyroid nodule and thyroid cancer. And the final topic I want to discuss is about incidental lowmass. What are we going to do with it? How are we going to, or do we have to assess them, etc., etc. When you look at the uptake mechanisms of both traces, there are some common features of the FDG uptake and iodine 124 uptake in thyroid cells. FDG, as you all know, is taken up by the glucose transporter. It is comparable to the glucose uptake, and after the first enzymatic step, it is trapped thereafter, in contrast to glucose, which goes further into the metabolic pathway. Highly important, the FDG uptake can be stimulated by insulin, and the higher the insulin levels, the higher the uptake will be in normal tissue. When you look at iodine 124, the uptake is via the sodium iodine symporter, and the uptake through this channel, and the uptake of iodine needs sodium, and that is why it's called a symporter. So without sodium, there is almost no uptake of iodine. Comparable to the stimulation of the FDG uptake, the uptake of iodine can be stimulated by TSH. And the higher the TSH level, the higher the iodine 124 uptake will be. And how is that achieved? Well, not only by an increase in metabolic steps, an increase in functioning of the symporter, but also the expression of the symporter increases. So there are more channels by TSH stimulation. Another important issue to realize is that when you stimulate a thyroid cell, it not only has effects on the sodium iodine symporter, but it has definitely also effects on the glucose metabolism. So the higher the TSH levels, the higher the iodine 124 uptake, but also the higher the FDG uptake will be. So if you want to visualize thyroid cells or thyroid cancer cells, you can realize from this perspective that stimulation of thyroid cells by TSH will improve the diagnostic accuracy of FDG PET scans. So an FDG PET scan without stimulation has lower results than with TSH stimulation. The patient preparation, therefore, is highly important. And when you look at the FDG PET scan in thyroid cancer or thyroid imaging, we know fasting is highly important. The competition with normal glucose should be in favor of the FDG. At least the patient has to stop insulin. And especially in case of thyroid cancer, stimulation with recombinant TSH is highly recommended to increase the yield. Of course, resting the activity with the standard PET-CT scans is now in a range of 180 to 240 megabecquerels. And what we do is a 60-minute post-injection scan of the patient. On the other hand, the iodine 124 PET-CT scan, well, in fact, it is a non-fasting scan. You can do an iodine 124 PET scan without fasting. The question is, what is the role of a diet, a low iodine diet, on the results? Well, we don't know yet. And I think in relation to the PET scan, the iodine 120 PET scan, currently there is no proof that a diet improves the diagnostic yield of an iodine 124 PET scan. It is good to stop Thyrax if possible, or stimulate the patient with recombinant TSH non-resting, and the activity is much lower, of course, than when you use or inject FGG. And the advantage of the Iodine 124 PET scan is that you can perform imaging after 24 to 48 hours, and that has all to do with the decay. Why is that so important? Well, you can combine the two tracers in a very practical mode. So what you can do is start on Monday and end up at Friday and do the whole procedure in 1 week. It is not a one-stop shop procedure because the patient has to come back each and every day. But this is on day 1, the recombinant TSH injection. On day 2, the second one. On day 3, you can do the FGG PET scan. And directly or shortly after the scan, you can inject Iodine 124 and then do the PET scan of that tracer on day 4 or day 5. And then at the end of the week, you have a complete idea of what's happening in the patient. So highly important to use such practical schemes. And because of this time schedule, we start on Monday and end up before weekend. Now, when we talk about the PET indications, well, the first thing is there a role in thyroid nodules? Well, I think it's highly important to simplify the functioning aspects of these nodules. When a patient has a thyroid nodule and he is suffering from hyperthyroidism, there is no indication for PET. There is no indication yet for PET. It's normal thyroid tissue that is hyperfunctioning, and why should we do FGG PET scanning? Of course, biochemistry is highly important, and of course, we need scintigraphy to assess what's going on. Is it multinodular goiter? Is it a solitary autonomic nodule? Or is it related to Graves' disease? So no indication in hyperthyroidism. When we talk about a nodule, a thyroid nodule, and a patient is euthyroid, it might be an indication. But first of all, the diagnostic strategy in case of a solitary nodule, a palpable solitary nodule, is of course ultrasonography, or when the nodule is large enough, you can go directly towards fine needle aspiration in cytology and see what's going on. And in most of these results are diagnostic, have a diagnostic value. However, there are patients that will undergo 1 or 2 aspirations, and then what do we have to do? If there is still a suspicion on malignancy, do we have to go on for a hemithyroidectomy or whatever? And that is highly important to make up your mind what you should do thereafter. In case of a non-hyperfunctioning nodule, there is no indication for scintigraphy, so don't do that in case of standard nodules. But the question is there a role for FGG PET scanning? And what do we know, and what have we learned from the data and literature? Well, first of all, it's highly important to realize that the data and literature on the role of FGG PET scanning in thyroid nodules is limited. So not much data is available on this topic. However, it's good to realize that the initial results in the literature presented is very good. You see here there are some nice papers on the role of FGG PET in thyroid nodules with a non-diagnostic cytology. Now, what do we learn from these papers? When you look at the results of this paper, you can see that when there is focal uptake observed in a known nodule, you can see that there is a huge variety of results found after surgery. Hyperplastic nodules, follicular adenoma, but also papillary thyroid cancer. And in this case, 18 patients with focally increased uptake had papillary thyroid cancer. And 9 patients with focally increased uptake had a follicular cancer. So what you can see is that the sensitivity of FGG PET is really, really high. The problem is, however, due to these results, the benign diseases or the benign entities, specificity is really disappointing. in a range of 60 to 70%. But this is maybe the most important result, the high negative predictive value, because all patients that did not have any focal uptake in the nodule did not have thyroid cancer. And that means that you can probably use FDG PET scanning to assess or to make up your strategy thereafter. And the conclusion of this study was that a negative PET scan accurately excludes malignancy in thyroid nodules with a non-diagnostic ultrasonography and fine needle cytology procedure. However, histology is still necessary to distinguish between benign and malignant diseases. And when you look at this paper, I think this was a very recent paper, that was not only dealing with incidental lomas, but also on the non-diagnostic fine needle aspiration and cytology results. You can see, in fact, comparable results. The overall sensitivity of FDG PET scan after an insufficient FNAC or FNAB biopsy is 100%. But again, you have to realize that the specificity is somewhere in a range of 50, 40, 60%, depending on, of course, the population that had been studied in this paper. But you can see, again, a very, very high negative predictive value. And based on these results, it was concluded that there is definitely a role for FDG PET scanning in patients with such nodules. Also, last year, and based on these results, the cost effectiveness was assessed of FDG PET scan for cytologically indeterminate thyroid nodules, and it was a decision analytic approach. And the most important conclusion of that study was that, of course, you can go straight forward to a hemithyroidectomy to establish the diagnosis, but that costs money. It has a high complication rate or not. There are other factors, how to go on with follow-up. And if you put FDG PET scanning into the whole diagnostic strategy, it has been regarded as highly cost-effective. So there might be, based on these results, a role for FDG PET scanning, but you have to realize that you have to go on when there is positive uptake or focally increased uptake. The step from nodules to incidental lomas is not that big as it might appear. When you do PET scanning in clinical practice, and especially in an oncological center, you may find quite often focally increased uptake on a PET scan. And the question, of course, is it a metastasis from a well-known primary tumor, or is it a new or a second primary tumor? When you look at the data that have been published so far, you can see from 2001 until 2012, quite a lot of papers have appeared in literature. And what was observed or concluded from all these papers is that the number of thyroid incidental lomas is not very high, but not to be neglected. And why not to be neglected? Well, you can see that here at the end. The number of incidental loma in all these papers range from, well, 1, 2, up till 9%. So it is really an incidental loma with not a very high incidence rate. But what you can see from this is that 30 to 50% of the incidental lomas turned out to be a malignancy. And that means that if you have an FDG positive focus on your PET scan, irrespective of the indication, you have to go on with further diagnosis, with ultrasonography and cytology. And then, of course, if ultrasonography is safe and radiologist says, okay, we have proof of benign aspects, then you can leave it. But if there is doubt, and if it's confirmed, you have to go on. And you can see here the results of what happened thereafter with all these patients presented in the paper. You can see here that most of the cases of malignancy were related to papillary thyroid cancer. Of course, there were also some case reports on follicular cancer, and here the Hürtel cell carcinoma. But it means that the risk on having a malignancy in the thyroid glands, a second primary tumor, cannot be neglected. And it is not a high risk, so focally increased uptake is not an indication for hemithyroidectomy. There is not a low risk for malignancy, so you cannot neglect it and say, okay, we do a thorough follow-up. But it is an intermediate risk on thyroid cancer, and that means that you have to go on with further diagnostics. Well, it was hoped that the SUV values could help you in differentiating between more benign or malignant nodule, but you can see here that in fact there is a huge overlap between benign foci and malignant foci, and it's maybe more or better presented on this slide. You see here a case of focally increased uptake. This is the SUV range of a benign nodule, and this is the range found in malignant tissue. And due to that, you cannot use the SUV values in clinical practice to differentiate between the benign and malignant entities. That is all about the thyroid nodules. Now, what about thyroid cancer? Well, you see here a typical example of a patient with elevated thyroglobulin levels who underwent treatment with radioiodine. You see here the uptake pattern, some normal excretion in the stomach or uptake here in the salivary glands, but no foci of increased uptake. And the question was, of course, where are the foci responsible for elevated thyroglobulin levels? And you see here a stimulated FDG PET scan showing multiple lesions in the chest being positive for metastatic thyroid cancer. Now, when we talk about thyroid cancer and the role of FDG PET, it is highly important to know something about the process during follow-up of thyroid cancer. The first step, which is in fact called the induction of thyroid cancer, is quite simple. But you have to realize that the expression of the sodium iodine symporter on thyroid cancer cells is already less optimal than is observed in normal thyroid tissue. And in fact, it means that you need more radioiodine to visualize malignant disease compared to normal thyroid tissue. So, in fact, what can be observed is that the radioiodine uptake is already diminished compared to normal thyroid cells. When there is progression of disease, a second dedifferentiation step may occur. And what does it mean? Well, that might have consequences on the expression of the sodium iodine symporter. And that means that the uptake of radioiodine is less than at the initial stage. So over time, it may lose its uptake capacity of radioiodine. And thereafter, TPO production, thyroglobulin production, and at the end of the whole dedifferentiation process, it might have consequences for the receptors expressed on the surface. For example, the TSH receptor, but also the somatostatin receptors. So you have to realize and keep that in mind. But what might help us is that over time, and in the process of dedifferentiation, the glucose metabolism increases. So at the initial stage, there is almost no FGG uptake in thyroid cancer. But at the end, when the tumor has turned out and to behave highly aggressive, you will definitely see increased FGG uptake in these cells. So at the initial stage, the standard follow-up of thyroid cancer is not so difficult. You have to rely on very, very common tests, and the most important two tests in the standard follow-up strategy of differentiated thyroid cancer is the stimulated thyroglobulin test and ultrasonography. And if they are both negative, there are no signs of recurrence, and you can send the patient safely home. And you see here why these tests have a very, very important role in the whole follow-up procedure. You see the very high sensitivity of stimulated thyroglobulin levels. It has the best results, in fact, in combination here with ultrasonography, and also a very, very high specificity. So if there is increased thyroglobulin level, it is highly indicative for recurrent thyroid cancer. But what are we going to do? What are we going to do when both tests fail, or one of the tests fail? Well, in fact, we might deal with dedifferentiated thyroid cancer, and that means that we can have patients with elevated stimulated thyroglobulin levels and a negative iodine 131 post-treatment scan. We can also have patients with positive iodine 131 post-treatment scans and normal thyroglobulin levels. So don't forget this group. It's very rare, but don't forget it. And what if both tests are negative? And there is a very, very high chance of recurrent disease. What are we going to do then when the standard tests fail? Well, here are the imaging options in radioiodine refractory differentiated thyroid cancer. Of course, ultrasonography to assess the local status of the neck, the head and neck region. CT scanning for the detection of local and metastatic disease, especially in the lungs and bone. MRI, very good option. But here you see at the end FDG PET scanning. And that is not only to detect metastatic disease, but it has also prognostic value. The FDG PET scan is highly important in assessing what can be expected in the upcoming months or years for a patient. And if you put all these tests in a scheme like this, and this is what we have developed in our hospital, you can see that here, in case of dedifferentiation, PET-CT should be applied as one of the first tests in clinical practice when there is a high chance on dedifferentiation. But also here at the end, in patients with negative tests, but with a very high suspicion on recurrent disease, there is probably a role for FDG PET-CT scanning. Now, what do we know about the diagnostic yield of FDG PET scanning in the follow-up of papillary and follicular thyroid cancer? I think that since the first presentation in 2001, there haven't appeared in literature other papers who were contra these results. And since then, I think it is the basis for FDG PET scanning in dedifferentiation. And why is that? Well, here, in fact, you see why FDG PET scanning is so important. This is the group of patients with metastatic disease and FDG uptake. And as you can see, prognosis is very, very poor, in contrast to the patients with a negative FDG PET scan. Another important issue is that there is also a very, very close correlation between the SUV value and final outcome. The higher the uptake of FDG, the poorer the prognosis is. And finally, there is also a very close relation between the number of lesions and outcome, the number of lesions observed on the FDG PET scan. And this is the reason why you should use recombinant TSH. You see more lesions than without TSH stimulation, and that has definitely consequences. So you upstage or downstage infected prognosis by using recombinant TSH. So an FDG PET scan without stimulation is in fact not good clinical practice. Well, the question is, of course, does PET change management in clinical practice in patients with elevated thyroglobulin levels? Well, you can see here patients with very low stimulated thyroglobulin levels. Well, the value of FDG PET scan is still limited. And why is that? Well, the chance of finding small lesions responsible for a thyroglobulin elevation between 1 and 10, the value is very limited. The chance of finding an abnormality is very, very low. And from these results, you can say, okay, when the thyroglobulin level is below 10, in fact, there is still no indication for PET scanning. On the other hand, when it is above that, you will definitely find the lesions in clinical practice. Just one small comment, and I think there are only 2 or 3 slides left. What about iodine 124 PET scanning? You see here a patient with a recurrent disease on the iodine 131 SPECT scan, so a post-treatment scan. It was negative on the iodine 124 PET scan. And the question is, what are we going to do with such things? When you look at the data and literature, they're a little bit confusing. You see here again an iodine 124 PET scan on the left side and a post-treatment scan on the right side. Well, based on the data and literature, you can see here the 2x2 table. Patients with recurrent disease, well, 12 out of 14 patients with recurrent disease had a negative iodine 124 PET scan. And when you look at the differences between the post-treatment iodine 131 scan and the iodine 124 PET scan, you see that 4 out of 5 patients with a positive post-treatment scan had a negative iodine 124 PET scan. So the role of iodine 124 PET scanning in current clinical practice is really a topic of discussion. We don't know yet what the value of it is. What if it's positive? Well, it might already have been observed on post-treatment scans. In our study that has recently been published from our institute, we had comparable results. So, in fact, there is a role for FDG PET scanning, but not as a regular test for iodine 124 PET scanning. In conclusion, FDG PET scanning, yes, it might be cost effective to apply it in patients with indifferent thyroid nodules. It has definitely prognostic value in the follow-up of thyroid cancer. Incidental lowmass require further analysis because of the intermediate risk on thyroid cancer, and the role of iodine 124 PET scanning is still not established in clinical practice. And I think it's now time for lunch.